All right. Good evening. Good afternoon. Great showing today for our wonderful speaker who will join us in just 1 minute. I'm Mike Udell. I am an associate professor here at the School of Public Health and wanted to thank all of you for joining us today for our fourth lecture in our Grand Round series this year. We have 2 more lectures coming up that I'll tell you quickly about before I bring up Dr. Craig Newshafer to introduce the speaker. On March 1st, is it? It'll come up in just a second. Bobby Reiter will be talking to us about migrant worker health. And in April, we are having Susan Reverby from Wellesley College come and talk to us about the Guatemala syphilis study. So those will be 2 outstanding talks. I hope to see a packed room like this for both of those talks as well, and thank all of you for coming today. Dr. Newshafer, would you be so kind to come up and introduce our speaker? Thank you.
Good afternoon, everybody. Sandro Galea is our speaker today. He's a physician, completed his medical training at the University of Toronto and did residences in family medicine and emergency medicine. He has an MPH from Harvard, a DRPH from Columbia, where he's now the Gelman Professor and Chair of the Department of Epidemiology at the Mailman School there. Between receiving his doctorate and returning to Columbia as chair, he worked for the Center for Urban Health Studies at the New York Academies of Medicine, had a junior faculty appointment at Columbia, and then spent 5-6 years in Michigan, where he ultimately was a tenured associate professor and directed the Center for Global Health there. So Sandro is widely acknowledged as one of the most creative and productive researchers in epidemiology today. No pressure. His primary research focus has been on the causes of mental disorders and the role of traumatic events in shaping population health, but he's always maintained this keen interest in unraveling how determinants at multiple levels, from the policy level, the broadest level, to neighborhood and community level indicators, down to genetic and other molecular indicators, how these things all work together to jointly affect the health of populations. So with this perspective in mind, he's written on specific topics that range from the psychological sequelae of 9/11 and 3/11 in Madrid, food insecurity, stressful life events and mental health outcomes in Africa, epigenetics and psychiatric morbidity, global burden of disease, particularly mental health, health inequalities and mental health outcomes among Arab Americans, and correlations between economic downturns and mental health. And that was just in the last year. So if you were to look at just the titles of the nearly 300 publications that are credited to his name, you'd be astounded by the breadth and depth of his work. And today, we're very pleased that he'll be speaking to us on trauma and mental health of global populations. Sandro.
Well, thank you for that very, very kind introduction. I think the only thing any reasonable person would do now would be to leave, because it's really all downhill from here. It's really an honor to be here. I'd like to thank Dr. Rich for inviting me, and Dr. Newshafer for hosting me. A lot of my work has been concerned with this notion of trauma and how trauma affects health of populations. And I was very pleased to be invited to speak about this topic in particular. And there are, we all, I think, at a certain point in our academic career do a range of things, but some things are closer to your heart than others. And I found myself very much taken by the import of trauma in shaping population health, and the import of trauma in shaping population health in both domestically and globally. So what I want to do today is give you a bit of an overview about why I think we should care about trauma and mental health. And then I thought, in terms of summarizing the field, I would just make 5 key points and use data from some of our studies in different parts of the world to make these points. So having said that, I'll plunge right in. So I'll start with why mental health. Hold on, I think I'm wired to walk, which would work well with my... Can you hear me okay? Okay. So why mental health? I think in public health in general, in schools of public health, we tend to, mental health tends to be in a corner, and it doesn't get anywhere near the prominence it deserves. And I'll explain why I think it deserves much more prominence. So this is, you all know about this, I'm sure, but this is the leading causes of burden of disease in the world, showing that it's a mental disorder, in particular depression, that will be causing the leading burden of disease anywhere in the world. But this is well known, but other things are less well known. So for example, this is the most costly medical conditions in the US, and what you actually see is that the most costly medical condition in the US is mental disorders, second followed by heart conditions. And when you think about it, it makes sense, because mental disorders are chronic and are associated with tremendous disability. And this is almost certainly an underestimate, because mental disorders are also associated with other physical conditions. And the link between mental disorders and physical disorders, while appreciated, is poorly quantified. It's actually very difficult to quantify, to put a dollar amount or an amount of disability that mental health contributes to physical health. The other aspect of mental health that I think bears focus in the context of public health is that mental health is vastly there's vastly less attention paid to it than it deserves. And this is a simple slide that shows that this is the burden of mental disorder and the proportion of national budgets for mental health. And if you just look down here, this is all countries in the world. Burden of mental disorder in this particular calculation is about 12%. Proportion of budgets is about 3.5%. It's about a quarter of the burden that is, if you were to say at a very simple level that we should at least be spending as much as a particular disorder contributes, we are globally underspending on mental disorders. And you see this in all countries, going from low-income countries to high-income countries. It's about a third to a quarter throughout. And you can also see this in the context of human resources for health. This is density of psychiatrists, psychologists, nurses, social workers per 100,000 population. And you see that anywhere except for sort of the Americas and Eurasia, you have quite a bit of low density of mental health professionals. So I could go on this, but I won't. But the three key points here are that mental disorders are common. Mental disorders contribute substantially to morbidity, and that disproportionately little attention is paid to mental disorders worldwide. And I think that disproportionately little attention extends to public health. It extends to the public health academic community. It extends to the public health practice community. And that mental health is, certainly in public health practice, historically has been relegated to the in-person service provision without really taking the systematic approach to understanding the drivers of mental disorders the same way as we do with chronic diseases, with things like cardiovascular disease and cancers. So that's the mental health. Now, the other part of my talk. So why trauma? Now, trauma is a very interesting phenomenon in that a little bit like divorce, it's one of those things that always happens to somebody else. And trauma is, we all have when I say the word trauma, you're all thinking about what trauma is in your own head. And it's typically one of those things that, well, it's a bad thing and it befalls others. So I just want to make the illustration that actually that's not true. The trauma, if you're just the dispassionate epidemiologist about it, trauma actually befalls nearly all of us. And as evidence actually by this is but this is the exact same slide I showed you before. I pointed out mental disorders before. Now actually I'm going to point out the third most costly, and the third most costly is trauma. So just simply at a domestic cost perspective, as I see it, if one is actually studying the intersection of this and this, you are really studying things that matter. And I think it's a sign of the relatively low emphasis that we put on these important conditions that I suspect most of you in the room, before I said that, would not have suggested that trauma and mental disorders together are two of the three most costly medical conditions in this country. And just to give us a sense of the prevalence, this is the universe, and the universe is construed of all blue people. And if you were to impose on it from any number of studies, about 90% of the population will experience a trauma at some point in their life. And this is shown in any number of studies. And in terms of in the past year, it depends on the population, but in many studies in high-risk populations, and by high risk you have things like urban populations, minority populations, you have about 50% of people who experience a traumatic event in any given year. And when you think about the sequelae associated with these traumatic events, you will then readily appreciate how this is a central driver of health in these populations. So I'm going to spend most of my talk on these sequelae. But I wanted to make a point about the ubiquity of these traumatic events, that this is not an exotic corner of drivers of health. I think globally and locally, we are dealing with something that should be much more central as a driver in our consideration. I want to show you a couple of maps around different kinds of traumas. This is a map looking at homicide, murders globally. And what you actually see here is there's been a rash of newspaper articles lately about how crime is dropping in big cities all over the U.S., although Philadelphia is a bit of an exception. But separate and apart from that local point of pride, the data about dropping crime in North America and Europe is masking actually an explosion of homicide murders in many parts of the low-income countries. And this is assault. Assault data is much harder to get. All the white here is just essentially missing data, but is certainly likely concentrated in Southeast Asia, Africa, and South America as well. And the reason assault is very, very difficult to get, and because it needs to be recorded by police, but it is in many surveys, it's probably the most common traumatic event that people are experiencing worldwide. So that's mental health and that's trauma. Now I just want to make a comment about the disasters. So it's a stream of my work has focused on disasters, which are really trauma just applied to many people at the same time. And I actually got interested in disasters largely because of that, is that if you're interested in trauma, it's hard not to be interested in these events where you have a large swath of the population exposed to a traumatic event at the same time. So I just want to talk a little bit about disasters. The word disaster comes from the Latin disastro, which means bad star. And so it's very much this notion that disasters are just bad stuff happening, and God imposes a bad thing upon us just because she is not happy with us. But increasingly the field is recognizing that that's actually false, because it is not, although our general impression is around idiosyncrasy, around bad things happening, ultimately the consequences of traumatic events are very much determined by a constellation of factors that are very much predictable and that we understand what they are. We can do something about them from a public health point of view. There are many definitions. There are actually whole books about what is a disaster, so I won't bore you with that. But this is my favorite definition, which is essentially it's a potentially traumatic event that's collectively experienced, has an acute onset, time delimited, and it's natural, technological, or human causes. And the point I want to make here on this definition is look at the phrase potentially traumatic event. And I think it's a very important phrase in that what it means is something happens, a tornado hits, a bomb explodes, and that is what is the disaster, but that is potentially traumatic. It doesn't have to be traumatic, meaning it doesn't have to have the consequences I'm going to talk about, because whether or not it has the consequences depends very much on our understanding of what could be the consequences and whether or not we intervene. And I think there are very much ways in which public health could intervene to mitigate some of these consequences. So, disasters, they're a common human experience. And now here's the part that often gets me in trouble, which is the part that actually disasters are an increasingly common human experience, that the disasters are increasing over time. And the reason that sort of gets one in trouble is because our conception of disasters as acts of God restricts us in some respects to say, well, why on earth would they be increasing over time? Is God more mad at us now than she was 20 years ago? Well, it's not that. There actually are two very clear, explicit reasons as to why disasters are increasing over time, so which I'll get to in a second. The thing about disasters is that you hear about some of them, and then you forget about them, and you don't hear about most of them. So just to make the point, this is the Fujikawa Japanese explosion of the reactor caused by things like this, just to give you a sense of sort of the badness of that. This is, people remember this? This is Haiti, where about 250,000 people died in the space of 21 seconds. And what this is for those who haven't seen the picture, this is the presidential palace. It's like the White House. It's actually hard to see it here, but I just want to point this out. Do you see this here? This is the first floor, right? You see this here? That's the second floor. So what it is we did a study there in Haiti. I'm not showing you data from it, but we did a study there where almost all the buildings in Port-au-Prince the second floors are pancaked. So essentially you have a first floor and the second floor. So what actually ended up happening, people here live and people here all die. And it literally was 21 seconds, which killed 250,000 people. There's a famous old disaster. This is the Chernobyl nuclear accident in 1985. Now, the thing about disasters is that you all know about Chernobyl, you all know about Haiti, you all know about Fujikawa. But if I were to ask you which disaster killed most people in the world in 2009, what would the answer be? It wasn't a small disaster. It killed over 1,000 people. Anybody remember? No, nobody remembers. Actually, I wouldn't remember either if I didn't look it up. But these events, it was actually an earthquake in Indonesia. Killed more than 1,000 people. India, another 1,000 people died with a flood, etc. This number of people killed. And then if I were to ask in 2009, which country had 3 of the top 10 disasters that actually affected most people, forget about killed, I bet, I'm sure somebody could guess, but it's actually China, which actually had, see this here? 3 disasters, 1990, that actually displaced 10, 13, and 40 million people. These are just vast, like large events. And we, as human beings, have this phenomenal capacity to have an event happen and then forget all about it. And the best part is, not only do we forget about it, we somehow think magically that another one is not going to happen again. So here's a statement, and you can all disagree with me later if you wish. I guess you can disagree now if you wish. Another bad disaster will happen somewhere in this country soon. And when I say that, you're all thinking, well, he's just jinxing. It's how he's guessing. I'm not guessing. We have decades of records that show the bad disasters happen on a fairly regular basis. It's not regular as in pinpoint to the day. I'm not talking about the Mayan calendar or Nostradamus. All I'm saying is that we know enough to know that these bad, large events will happen. They do happen consistently, reliably. So when you think of it that way, it moves our thinking about trauma and large-scale trauma out of this niche of it's something that happens sporadically. We never know when it's going to happen. And when it does happen, we'll scramble to fix it. And to something that actually does happen regularly. It is as regular and as recurring an event as our other epidemics. So I think it's a shift that we need to make in public health to think of trauma as a ongoing driver. That's something that we need to look into, understand, and think about in our public health approach, how we may intervene about it, just as we do with other things. This is Hurricane Katrina, which some of you will remember, 2005. And the point I want to make about Hurricane Katrina is the size of these events. So this is Louisiana and Mississippi, and these are the areas, the colored areas here are areas that were declared a federal disaster zone. So this federal disaster zone requires certain criteria. Things need to be sort of bad. And you all look at that and say, okay, well, it was bad, it was a large area. But here's the point. The areas of Mississippi and Louisiana, just Mississippi and Louisiana, added up that were declared a federal disaster zone were equivalent in size geographically to the entire United Kingdom. So it's psychologically, we consistently underestimate how large these things were. I would argue that if in 2005 the entire United Kingdom was a disaster area, you would hear a lot more about the great United Kingdom disaster of 2005 today than you hear about Hurricane Katrina today. So it is, again, we're dealing with large-scale events that happen regularly, traumatic events that happen regularly that affect nearly all of us. This is now my the proof of what I said before. The disasters are increasing over time, 1975 all the way up to 2000. And so why are disasters increasing over time? It's not a God issue. It's actually, this is another one showing all disasters and earthquakes increasing. And the reason is actually very simple. There are 2 reasons. One is that we are squishing more and more people in cities, and we are, let me rephrase my second one. The number of environmental emergencies are increasing largely due to climate change. So I'm actually not going to touch the second one because I'm not a climatologist. I'm not going to get into the causes and all that, but it seems pretty incontrovertible that there are changes in global climate that are resulting in more hydrological emergencies. So there's no question about that. But accepting that one, the first one is actually bears some thought for a second. We forget that urbanization is the single largest, most important demographic shift of human populations in the past 100 years. And just to give you a bit of a sense of the scope of that, this is global population living in cities, 1950 to 2000. This is high-income country global population, low-income countries. This is where actually most of the growth is in urban populations. And just a few facts. By 2010, there are 2.5 billion people who are living in cities, which is actually like the entire world in 1950. So the entire world of 1950 is now all here but living in cities. And usually we think of Africa, you think of Africa as a rural place, but actually there are more people living in cities in Africa than there are living in North America. And just to make this point graphically, this is the world in 1960. And what I'm doing is I'm shading in dark blue the countries in the world where at least half the population lives in cities. So it's 1960, 70. Essentially the whole world's urban by 2050, right? So what's happening is we're squishing people more into cities. And now, for those of you who remember any form of urban planning class in undergrad, well, where are cities built? Cities are always are built in desirable places. Desirable places for human beings tend to be on water, and a large number of disasters are hydrological. And the squishing of people together means that even human-made disasters that have a lot more people around them who can get affected. So there are good reasons why trauma and large-scale trauma is becoming more common. It's not magic, it's just there are good rational reasons why that's the case. This is just to give you a bit of a sense of the world the urban population is. And this is now the sort of putting the icing on this particular cake, and this is the population in large cities exposed to cyclones. And what you see is, there's a bit of a legend here about countries in the world, and what you see is, the population of cities exposed to cyclones is increasing, and the population of cities exposed to earthquakes is also increasing. So essentially, we have a situation where we are, through climate change, affecting weather conditions that mean that the patterns of naturally occurring mass traumatic events is changing to greater frequency. And through demographic shifts, we are essentially putting more people in direct harm's way, if you want to call this harm's way, that there are more and more people now exposed to these events. So if you buy my argument that trauma matters, the corollary argument is that trauma matters more and is going to matter more, which of course means that we, in the academic public health community, it behooves us to be very cognizant of this and to think about both research as well as interventions in this area. And one last point on this is that one of the things that actually happens, and why I'm circling back to mental health, is that as medicine, clinical care in the acute term after traumatic event experience has gotten better, what we're seeing is a shift in the morbidity after these events from to have mental health mattering more and more, because we are saving more and more lives after these events. And the best data on this actually is among soldiers, and this is just a wounded to killed ratio in World War II, Vietnam, and Operation Iraqi Freedom. And what you see is it was 2-to-1, meaning the number of people wounded to killed in World War II, 3-to-1 in Vietnam, and 7-to-1 in the war in Iraq. And this is the reason it's helpful to look at soldiers here, is just because the data on this is comparable and very useful. But it's the same throughout other traumatic events. So we have gotten better at avoiding loss of life. As a result, we're shifting the burden to more mental health issues. So I'm now going to switch then to what happens. So what happens? What happens to mental health after large-scale traumatic events? And obviously this is a subject of books, and one could actually talk a lot about, spend a lot of time on it. So as I was thinking about it, I thought I would make 5 points on this. And I'm going to use illustrations from multiple events to make these 5 points. So the first one is about the burden of psychopathology and its path. The range of psychopathology, number 2. The third point is about groups. The fourth one is about the role of ongoing stressors. And the fifth one is around the link between psychopathology and health behavior. So let me go through one by one. And I'm going to use data. I'm using data from several of our studies around the world. There are other people who've done other studies, of course, that are relevant here, but I'm just focusing on our work for this part. So let me start with the first one. We know, no, that doesn't work. Okay. I clearly cannot move. That's fine. We know that after these events, there is a large burden of psychopathology. And what we also are increasingly getting to know is that their course, how psychopathology works over time, is complicated. So let me just show you some data from the 10 years ago, the September 11 terrorist attacks. So we did this study which sampled the entire New York metropolitan area. This is New York City. This is the area around, obviously. We're somewhere over here. So it's what you have here is eastern New Jersey, Long Island. This is Connecticut. And what you see here is the density of the color is reflecting the burden of post-traumatic stress disorder. So PTSD density is higher, closer to the World Trade Center. World Trade Center was right there, and it gets less as you go out, which makes a lot of sense because the people who are closer to the World Trade Center were more likely to be exposed to traumatic events. The burden of PTSD is in the New York City is in the 7 to 8% range, depending on the borough. And what you see here is I want to make a point that you see how this is Manhattan right here, how the color is lighter than it was in either the Bronx or in Brooklyn. And the reason for that is because the exposure to the traumatic event, in this case the collapse of the World Trade Center, was actually higher in these outer boroughs. Because of Brooklyn, largely because of sightlines, for those who know New York City, actually World Trade Center was closer to Brooklyn in terms of people being directly exposed to it. And the Bronx, because one of the key drivers of a burden of mental disorder in this context was actually being Latino, and Latinos are much more populous in the Bronx. I'm going to show you that in a second. Now, we published this paper in about, I can't remember, 8-9 months of September 11th, which showed just ignore this part, this is more technical detail, but if you focus here, what you see is that the prevalence started off high and actually went low over the first 6 months after September 11th. And it's one of those papers that we actually published and afterwards felt, well, I probably should have waited another year before publishing the paper, because this is the first 6 months, but actually what the paper didn't show is that, which actually happened in the next 2 or 3 years after. So this pattern is that the prevalence starts high, it goes down in the first few months and then plateaus, goes back higher and plateaus. There are not that many studies after large-scale disasters that are longitudinal, but the ones that are seem to confirm it. That what you have is, you have this plateau, which is, you have this dip, which is probably due to the large infusion of social supportive resources that people are experiencing in the first few months after an event, and then this increase, which then stays in the long term. What's fascinating here about the trajectory is that the fact that it starts high and goes down is not surprising. The re-increase is perhaps surprising, but what's fascinating is this permanent increase. And in studies, there are very few studies that are able to follow people after trauma in the long term, but the ones that have show this pattern consistently, in that after a trauma, a large-scale trauma, a certain proportion of people continue to have a burden of psychopathology that they didn't have before. Essentially, you've shifted the population burden, that you've shifted the baseline in populations. And that is true of large-scale traumatic events, and it's probably true of situations where you have ongoing recurrent individual traumas, like urban populations, which are exposed to a lot of violence, or populations exposed to war, where what you're doing is you are, in public health parlance, you are shifting the curve of disease, in that you are creating a population where there is a greater burden of mental illness than there otherwise would have been had the traumatic event not happened. Now, in terms of the trajectory being complicated, I'm going to take this line and I'm going to break it up into two. So if you look at the orange line, and now what I have is that this dotted orange line is just what I was showing you before, but I've split it into two, the red group and the blue group. The red group are people who were exposed to a lot of traumas on September 11th, and the blue group are people who weren't exposed to a lot of traumas. And there are 2 points about this trajectory. One of them is that both lines have the same shape, that both lines do that. The second key point, though, is that the blue people exist. So here's the point. These are people who were directly exposed to a lot of traumas. The blue people are people who are not. And the point I want to make here is that when we tend to think of risk within public health, we tend to think of this concept of risk, and we tend to think only of the red groups. We tend to think of people who are at high risk. But we forget the people who are at low risk, who have similar patterns to people in high risk. And at a population level, the reason these large-scale traumatic events or large-scale exposures of any kind matter is that there are more of these people than those people. And I'll come back to this point later. So that's one point about splitting the orange line. And then I can also split the orange line another way. This is actually looking at the purple now are Latinos and the green are non-Latinos, everybody else. I made the point earlier about Latinos being higher, and what you actually see is, the point I'm making here is that our notion of a static risk factor, if I told you Latinos were at greater risk of PTSD, it's not a matter of they had greater risk of PTSD in the short term, they actually had a greater risk of post-traumatic stress disorder continuing over time throughout the entire trajectory of mental disorders over time. Now, a much more interesting way to look at trajectories is to take this trajectory over time and to break it up into individual patterns that constitute this. Because by doing that, we can actually figure out what are the individual trajectories and the groups of people who have different trajectories, so that we may figure out how to intervene. And you can do that through latent class analysis. I'll spare us all the technical detail, but essentially what you have here is we have the same data set, same number of time, and these are symptoms of PTSD. And what we've done here is we've conducted this latent class analysis to figure out the different types of people who are constituting that overall curve that you saw. And what you see here is a bunch of lines, but I just want to draw your attention to a couple of them. I've put here now percentages of people who dwell in these lines. So here's a first point. The black line down here, you see it down here? It says 40%. Even in an event that is large scale, like September 11th, where a lot of people are affected, we find time and time again that if not a majority, a plurality of people are just fine. So I want to use the slide to make this point. I'm talking about trauma and mental health, right? So a lot of my talk centers around trauma and its adverse psychopathology. But I do want to make the point that buried and lost in a talk like mine often is the case, that we forget that most people after trauma are resistant to the effect of trauma, meaning most people are actually okay. And we tend to forget that, and actually in public health we tend to forget about all risk factors. You think of risk factors causes badness, we tend to forget that actually most people exposed to risk factor do not have the badness, whatever it is. So I just wanted to make that point. Then you have the other key lines. You have here this orange line, which is a resilient group that actually was affected but then got better quickly. But then you also have this group with consistently bad symptoms, but 10% here. And then you have these groups with sort of middling symptoms. And just focusing on these four large groups for a second, these are patterns that are, I think, bear reflection for a second, that after traumatic event, there is a pattern of resistance, that's the black group, resilience, the orange group, this moderate dysfunction, which is the blue group, you see they continue to have symptoms in the long term, a recovery group, and a chronic dysfunction group. Now, if this were just one isolated example of trajectories, it would be interesting, but not particularly informative, but we actually have replicated this in other places. This is, I'm going to show you data from a study that we did after mudslides in Tezuitlan. This is a tropical depression, which results in an enormous amount of rain, results in mudslides, is one of the leading causes of morbidity and mortality in many low-income countries because of urbanization and poorly built housing. And here, we followed up groups over time, and what you actually see is the exact same patterns: a resistant group, a resilient group, moderate dysfunction group, a recovery group, and a chronic dysfunction group. This is from a paper that we published a few years ago, which actually talks about the potential post-trauma trajectories, where this is a schematic of what I showed you here: a resistant group, a resilient group, chronic dysfunction group. There's also delayed dysfunction and a relapsing remitting group. But I actually think we have enough evidence now to be able to say pretty clearly that we're going to have one of these 6 patterns of behavior after these kind of events, that the pattern of psychopathology after trauma is non-monotonic. We know determinants, which I'm not going to get into in the interest of time, that put people on these groups, and understanding which group people are on is one of the key paths towards intervention. Okay, so that's point 1. Let me move to point 2. The point 2 is that the range of psychopathology experienced after these events is broad. So I jumped straight into post-traumatic stress disorder without telling you much about it, and I'm not going to get into it, but post-traumatic stress disorder is the sentinel disorder that's studied after trauma for many reasons. But in studying post-traumatic stress disorder, we far too frequently forget about a broad range of other disorders that happen after disasters. And in the few studies that have looked at a full range of psychopathology, we find that PTSD is the proverbial tip of the iceberg. So this is a study that we did that Craig in his introduction mentioned, which was after the March 11th 2004 terrorist bombings. This was, for those of you who don't remember, it was exactly 2.5 years after September 11th. It was an Al-Qaeda bomb, which was timed to be 2.5 years after 9/11, and it was the largest terrorist attack ever in Europe. And to give you a sense of where it was, this is Madrid, for those of you who haven't been there. It's a lovely, lovely city. And it's a circle, and the trains came from the suburb of Alcalá and were going to Madrid, to downtown Madrid. And this was actually one of the few times in history, perhaps, where unionized faculty in a university were directly responsible for saving a lot of lives at the same time. And let me explain why. In the faculty at the largest university in Madrid, which is the Universidad Complutense, which is right there, called a wildcat strike just the night before March 11th. And so faculty shut down the university that day unexpectedly. And this train from here to there carried two kinds of people, carried university students and carried blue-collar workers. So actually there were no university students on the train. So actually the intended death toll was far more than 200. It would have been much more than 200 if it wasn't for university faculty saving the day, as we always do. It was a devastating event, but it was quite different than September 11th in that the trains in European countries, because European countries have progressive notions about silly things like public transportation, are actually well covered. So they're not visible. September 11th was a very visible event, and this has actually implications for what psychopathology is manifest after these events. Post-traumatic stress disorder depends very much on the visibility and direct exposure to trauma, while other psychopathology, like depression, tends to happen when you have a rupture in social fabric that really has nothing to do with the visibility of the traumatic event. And this is the prevalence of PTSD after the March 11 train bombing. And I want to show you different groups. These are people who are injured. These were residents of the suburb where the trains came from, which is essentially the family members of those who were injured or killed. This is the police, and this is the general population of Madrid. So remember, in New York, in the general population, I said the prevalence was about 7 to 8%. Here, it's a much lower prevalence. The higher prevalence is among those injured and the relatives of those injured. I think it was something I said. Do you all hear it, or is it just in my head? That's okay. I thought it was actually coming from behind me. Having one of those moments. Okay. So what you see here is that the injured have a fairly high prevalence, which is actually consistent in many studies throughout. The relatives are also high, but you see something interesting here. You see how the police is actually quite low. And there are many studies that show that among the groups that are most affected by the consequences of trauma are rescue workers. And here the police is surprisingly low, but the reason it is because this was a very experienced group of police officers who had all previously dealt with prior terrorist attacks, principally due to terrorist attacks from the ETA Basque separatist group, which Spain has had a long problem with for many years. And the low prevalence, in Madrid is a reflection of the fact that this was not a very visible event. By contrast, you look at depression, you see the prevalence of injured, here high, residents of Alcalá, and you see the prevalence of depression now in Madrid being high. So there are these patterns that very much reflect and are linked with the type of event. But when I expand the lens to take us to all the psychopathology, PTSD, depression, agoraphobia, GAD, panic, which we were able to do in this study, and you have the population of injured residents of Alcalá and the police, what I want you to look at here is this prevalence versus this prevalence. If you look at Alcalá, you have 12% versus 30%. PTSD 44 to almost 60%, police 1 to almost 6%. In that if you're looking only at particular disorders, you are going to miss about 1/3 to 1/2 of the burden of psychopathology. And most studies of trauma focus only on post-traumatic stress disorder or PTSD and depression, missing a substantial portion of psychopathology. Okay, point 3. So certain groups are more vulnerable after these events than others. We tend to think of trauma, I think in part because of its exogenous nature, as in trauma will happen and it will affect anybody. It will affect anybody, and we're all vulnerable to trauma. We all are. But we're not all equally vulnerable. And there are many different reasons why, and many different reasons we understand why some groups are more vulnerable than others. So I want to show you two particular examples on that. I'm going to start with a study that we did in Ethiopia. And this is where Ethiopia is. And the study we did was in southwest Ethiopia, around Jimma. Over here is the area called the Gilgil-Gibe area. It's an interesting area from a public health point of view, although not so much if you're a resident there. It's a very classic tale of building a dam, displacing large populations, resulting in dramatic population conflicts. It was a high conflict area for many years. And we did this study. We're particularly interested in the intergenerational transmission of trauma in this particular context, to look at children and what the impact of the parents' experience of trauma was on children. So this is a slide that looks at the experience of traumatic events by residents of the Gilgil-Gibe region in Ethiopia. And what you have here, black is women and white is men in these bars. This is number of traumas that they experienced. And what you see is a couple of things. First of all, the modal number of traumas for women is about 3, for men it's about 5. This is a lot. To experience 3 to 5 traumatic events is a lot, when in certain North American populations, most people are experiencing 1. Then you see the curve is over here, while men is over here. Men have a higher exposure to traumatic events, largely because men were caught up in the act of fighting. And that a lot of the extra traumatic events that men were experiencing were directly related to conflict and war. There is a very classic dose-response relationship between traumatic events experienced and likelihood of PTSD. And I can show you this curve in any of the traumatic events I'm showing you today. But more events experienced, more likely you are to have PTSD. There is no single greater driver of psychopathology after trauma than experiencing many traumas. One of the questions that sometimes I get is, well, what about if you experience a lot of traumas, does it inoculate you? The whole notion of inoculation after traumatic events, as far as I'm concerned, is outdated. So there is plenty of evidence that there is no inoculation. The more traumatic events, the more likely you are to have psychopathology of some stripe or another. And this actually looks at the number of traumatic events and depression, not just PTSD, but also depression. Again, this is men and women. This is a predicted probability. Now, the other thing we're interested in here was children. So we actually did a formal assessment of child development using the Denver Developmental Scale, which is an objective scale where you look at children's speech, dressing themselves, stacking blocks, jumping, things like that. And this is looking at the Denver Developmental Scale, and this is looking at different kinds of development: personal, social, fine motor, language, gross motor. And the only point I want to make here is, as kids get older, you see this, 3 months all the way to 44 months. As kids get older, they're getting better in all these scales. And the only point is making this makes total sense, right? As kids get older, they're developing. But then look at the scale. And what I want you to look at here is there are 2 kinds of kids. The black kids are kids whose mothers were depressed, and the white kids are kids whose mothers were not depressed. And what you see is, as kids get older, they're all developing more, but the kids whose mothers are depressed are developing more slowly. And this is to try to make the point about the intergenerational transmission of these events, and that there are vulnerable groups, not just in directly people who are affected to trauma, but also vulnerable groups who are in the subsequent generation. And the question of why this is very interesting. And it's probably a combination of factors. I suspect that this involves as much an epigenetic process about changes in gene expression in the children that's related to neuroplasticity and development, as much as it is around shared context of women who have more likely to be depressed having different context than ones who are not, as much as it has to be with different behavior and different parenting styles in women who are depressed and women who are not. So the whole argument as to why is a whole other hour discussion, which I won't get into. But the point is that there is here pretty clear evidence in this and other studies that there is an intergenerational process, intergenerational transmission of these traumatic events from parents to their offspring. Now, to continue making the point about certain groups being more vulnerable, this is another bombing. This is actually from the second Intifada, the Al-Aqsa Intifada in Israel, which started in 2000. We did a series of studies there. And the series of studies involved, we did population samples of people living in Israel, which involved both Jewish residents of Israel as well as Arab residents of Israel. This is all in Israel pre-1967 boundaries, although we did some other studies later in the territories. But so these are all citizens of Israel, people with Israeli passports, but of two stripes, Arabs and Jews. And what we did is here now we're looking at the prevalence of PTSD, and this actually, the label is wrong. The label, more correctly, should say Arab. But anyway, almost all Arabs are actually Palestinian, but in this context. But what you see is threefold greater prevalence of PTSD in the Arab population than is in the Jewish population. And now you might say, well, maybe it's because, remember, this is the Intifada, this bombings inside Israel, and I would argue that until you saw the slide, most of you have always thought of that as ultimately affecting Jewish residents of Israel. But in fact, it was affecting the Arab residents of Israel more, certainly from a mental health point of view. We looked at this in multiple ways. We're breaking this down into different symptom components of PTSD, and what you actually see is here, you see this pattern is exactly the same pattern between the Jews and the Arabs, only they are much lower. And then we did a series of analyses trying to understand why this was. And what you have here is, these are a series of models, and what you're looking at is the likelihood, the odds ratio of the increased likelihood of PTSD among Arabs versus Jewish residents of Israel. And you go down, you can reduce this by about 39%. But in Model 4, you still have about a 90% greater odds of post-traumatic stress in Arabs versus Jews. And now the question is, what's Model 4? Well, you actually have to read down here. So this is adjusting for sex, age, income, education, religiosity, direct exposure to trauma, threat from conflict, economic loss, psychosocial loss, traumatic growth, social support. In other words, we're actually taking into account more or less everything that we can think of that we know explains post-traumatic stress disorder after experience to a traumatic event. And you still have about 90% greater likelihood of PTSD among the Arab versus Jewish residents of Israel. Which means, of course, something else is going on. And I think, we don't know what's going on, but I think in this case what it is what we're picking up is the tremendous economic and social disadvantage at which the Arab residents of Israel versus Jewish residents of Israel are at, that is ultimately manifesting in greater vulnerability to psychopathology after traumatic events. And I think this has implications for work that's done in this country when one is dealing with vulnerable populations, minority populations, and the greater vulnerability those groups are at. And I can show you this kind of pattern in many other studies, but I'm showing you this one because I think it's a nice extreme illustration of two groups, and one group which one does not think of being particular risk, being at much greater risk here. Okay, point 4, about ongoing stressors and traumas. So one of the problems with studying trauma, and in particular a problem with studying large-scale traumatic events like disasters, is that, at least in the short term, everybody cares about the trauma. Everybody cares about the index trauma or the index disaster. And we tend to say, okay, so a bad thing happened, a hurricane happened, or an assault happened, or a car accident happened, or a bomb happened, and then tell me what happens afterwards, tell me what happened that's due to that event. The problem is this, is that yes, bad things happen, psychopathology happens due to that event, but life also happens. And life also brings with it stressors and other traumas. And increasingly we are beginning to realize that it is a life course perspective that combines the sentinel event with other events that gives us an understanding of the course of psychopathology after these events. That focusing only on the sentinel event is missing a large part of the story. So I want to show you a couple of illustrations on that. I'll start off with a study that we did in Liberia. Liberia is right here in the Horn of Africa, southwest. It's an interesting country in that it was it was started by freed American slaves. Liberia had the misfortune of going through a civil war for about 20 years. We did this study in Nimba County, which is a county in northeast Liberia. It's the largest county in Liberia with a population representative study. And I want to show you just some data from it. This is the prevalence in the population of people who were in war, lack of food or shelter in their life, ill health, lack of shelter. You see down here? We're dealing with a highly exposed population. See, about 90% exposed to war. This population was very much exposed to war. Now, Nimba County, the province we did the study in, had the distinction of being the county where the war started. The good thing for Nimba County was that actually there was no war for about 20 years. We did the study I think 3 years ago. And there had been no war really in the county for about 20 years before, because that's where the war started. Then it migrated down to Monrovia, and that's where the war went on for the past 20 years. But Nimba County has been peaceful for about 20 years. And this is a map, this is a historical map, and this is the shape of Nimba County. And what you actually see here is, you can't really read it from there, but you see these numbers, 1, 2, 3, 4, 5, 6, 7, 8. These are historical markers in the war. These are things that happened 20 years ago. Essentially, this is Sierra Leone over here. Charles Taylor's army, which is the Lord's army, came in from here, and they essentially killed, pillaged their way down through Nimba County this way, along the road, and then went down this way towards Monrovia. So this is a path of conflict. Now, 20 years later, look at this map. This is now a path of psychopathology. So what you actually see here is the psychopathology in villages. These dots are all the villages we sampled, and what you see is the density of psychopathology in villages. This is the high burden villages, and this is now the PTSD, which you see it following the same path. So what you see here is history is writing a path of trauma. And 20 years later, you're still seeing the psychopathology in these communities. And what's amazing is you can actually see the psychopathology even in people who were very young in these villages when the war went through. And actually one of the interesting, it was an interesting paper to write, because we had a very interesting exchange with the reviewers about, well, how is it possible that you're saying there's a path of traumas being written, but some of these people were like 2 years old, 3 years old when the war went through. And I think what's going on is the psychopathology is not due to the war. This is actually due to other things that are going on. And in these communities which are ravaged by war, by large traumatic events, they have other traumas. They have higher prevalence of other traumas, higher prevalence of other stressors that makes people in them more vulnerable. In the final paper, we removed people from the sample, because we had to by reviewers, who were not born when the war happened 20 years before. But I only took them out because the reviewers insisted, but actually in those people there was very much a clear pattern as well, which I think reflects the intergenerational transmission that I showed you before. So that's one illustration about the ongoing traumas. And I show you another illustration from Hurricane Katrina in the Gulf of Mexico. This looks at the course of PTSD. And what you have here is this survival curve. For those of you who don't know a survival curve, what it is I'm taking everybody with post-traumatic stress disorder here, and I'm following them over time. These are days, it's like 600 days, so it's about 2 years. And I'm looking at the course of symptoms of PTSD and dividing it into two, among people with high stressors and people with low stressors. Now, by stressors here, this is not traumas. These are not traumatic events like assault, car accidents, rapes. These are financial stressors, not being able to put your kid into school, not being able to find a job. And what you see is that So what you see here is that sorry, I'm back. It's one of those, realign chip in head. Back. Okay, what you see is that those who are not exposed to stressors, their PTSD resolved much more quickly than those who were exposed to stressors. Now, if you stop and think about it for a second, you'll say, what should not being able to get a job, not being able to put your kids in school, what does that have to do with post-traumatic stress disorder, which is about trauma? It's about symptoms after trauma. But what it is the burden of other adversity in life is ultimately associated with this greater pattern of vulnerability that is manifest here by a different, longer course of PTSD. Now, why that is, as I said, this is a subject of another presentation, which I'm glad to come back into another hour on mechanisms, because I think there's some very interesting mechanisms. I think the mechanisms range from the biological to the sociological as to why this is going on. But the lesson is, from both these examples, is that we cannot think of trauma as only the sentinel trauma. We need to think about the ongoing other life events. I think increasingly we need to think of trauma within a life course perspective to understand how the full exposure of people to life's events is ultimately what's shaping psychopathology, which is what we care about. Point 5, psychopathology drives health behavior, physical health, and use of health services. So I'm going to use only 3 slides for this part, and I feel like In some respects, I probably should have used 100 slides on this part, because I think this is a central part to our understanding of the burden of psychopathology. And that this goes back to my point at the beginning. Mental health doesn't exist in isolation. Mental health ultimately is influencing all other aspects of people's health. And in particular, it's influencing health behavior, physical health, and our service use, which we all care about. So this is I'm going back to the September 11 data set now that I started with. And what you have here is a table, but if you just look at people with post-traumatic stress disorder, and you look at, just look here, the table is very busy, but what you see is PTSD people increasing cigarettes, yes, no. And what you see is that those who had PTSD are much more likely to smoke more. Those with depression are much more likely to smoke more. And I could show you this for many other health behaviors. Psychopathology is associated with adverse health behaviors. Now let me switch from health behaviors and go to something like asthma. And what this is people with PTSD in green, no PTSD in blue. And what you see here is asthma symptoms. You see people with PTSD, people without PTSD. Now, you can say, well, it's asthma symptoms, so what's going on? Is people with PTSD just complaining? Well, there are actually many physiological reasons why post-traumatic stress disorder, which probably is at some level a disruption of normal immune axes, is also associated with more asthma symptoms. But even leaving that aside, leaving aside whether this is a physiologic process at the level of airway obstruction, or whether this is a reflection, the fact that people with psychopathology are more likely to report symptoms. Look now at this. Emergency room visits and unscheduled physician visits. Look at the number of unscheduled physician visits in the green among people with PTSD. And these are unscheduled physician visits due to asthma. So after September 11th, people with unscheduled physician visits due to asthma, these people, they're not going to their doctor saying that I'm having nightmares, flashbacks, I'm feeling jumpy. They're not going to the doctor complaining about symptoms of PTSD. They're complaining of symptoms of asthma. They were 3 times more likely to have PTSD than the ones who were not. So regardless of the mechanism, psychopathology is associated with this greater burden of physical symptoms and a change in healthcare use and change in the pattern of healthcare use that ultimately is driving what we see in our system. And this is looking at the Medicaid recipients and their SSRI, serotonin reuptake inhibitors, prescriptions after September 11th. And what I want to show you here is where people lived in relation to the World Trade Center site. And this is September to October 2001. So this is right after September 11th. And this is January, September 2001. So this is before September 11th. And what you see here is the difference in the post versus pre-9/11. And look here at the increase close to World Trade Center, 18% increase in medication use, 14% as you go further away, to 9% as you go even further away. Now, in order to control this, what we did is actually we also looked, of course, at temporal periods. We looked at September to December in 2000. And what you see is actually there was no difference post and pre-September 2000. You see these differences there? There are actually no difference. So September 11th was associated with an increase in medication use, which was lower the further away you went from the World Trade Center. The point is that psychopathology is the tip of the iceberg in so many ways. It is also associated with physical health, associated with use of health services, and use of things like prescription. And if you think of something like Medicaid, these are large systems that ultimately are being affected quite profoundly by these large-scale traumatic events. Okay, so let me wrap up. I just want to make a few concluding points that, in the context of trauma. This first point is this, which is it's important to keep in mind what we know and why we know it. And this is particularly important in the context of studying global populations. So my talk is labeled as mental health in global populations. And this is a review paper that we did, citation of which you cannot see is down there. And what we looked at was specifically the number of terrorist events worldwide. This is now pretty old. This is, I think, 7 years old. And we also looked at something else. We actually looked at number of studies of events. So the black bar is number of events, and the gray bar is number of studies. So what you see, a high correlation that the science, the global science, is really studying exactly where the events are, which is not true. So the point I want to make is that actually if you're really interested in global events, we have to keep in mind that actually our global science in public health is really distorted, and that our understanding of global events is very much filtered through a Western high-income country lens. So this is more of a caveat in everything I've told you. This is a picture from a particular traumatic event, the bombing of the Murrah building in Oklahoma City in 1993. And the reason I'm using this event is because it's actually the best picture I know of this phenomenon, which is pretty universal. This is the Murrah building, and the bomb was right here. And what you have here are green people who died, and I'm sorry, red people who died, and this dark green are people who were not injured. And the point I want to make, this was, so they mapped out everybody in the building. And the point I want to make is that when you have traumatic events that are widespread, you often have this tremendous proximity when people who died, people who were actually not even injured, people who died who were not even injured, right side by side. There is a certain physical idiosyncrasy in extreme injuries after these events, which means that we frequently miss people who are at risk for psychopathology because they are not physically injured, but in fact they were exposed to tremendous burden of traumatic event, which we frequently forget. And I've never seen anything like this done around, for example, urban violence, but I bet you could map out much the same thing with urban violence. A third point. This is the point. I'm now going to go back to the point I made in my first point about trajectory of psychopathology, but put it in a slightly different way, because I think it's an important point. So this is the world. I'm dividing the world into blue people and red people. And red people are people who are at risk, who are directly affected by a disaster. Let's say blue people are people who are not. In almost any event, any large-scale event, it's almost always a minority of people who are directly affected by an event. It's just because, particularly when events hit large, densely populated areas, there are just a lot of people in these areas. Even something like September 11th, something like Hurricane Katrina, most people are not directly affected. Now, the people who are directly affected are the ones who bear the greatest burden of psychopathology. I've made this point again and again. So I'm imposing now here the burden of psychopathology. So for those of you who are epidemiologically minded, you'll recognize that the risk of psychopathology here is greater than here, because risk is yellow over red, right? Yellow over red is bigger than yellow over blue, because red is the denominator here is smaller. So this is no question a higher risk. But the point is that in absolute terms, yellow here is the same as yellow there. So one of the interesting phenomena about large-scale traumatic events is that it's a classic example how the burden of disease gives us a different lens on the consequences from a public health perspective than does the relative risk and looking at people who are at high risk. So it poses a particular challenge for public health response in terms of, are we focusing here or are we focusing there? And the corollary to this, which I'm not going to show you, but I will just tell you, is that this group, who is the red group, changes over time, which means that this group changes over time and the relative proportions of these two groups change over time. So it poses a particular challenge for public health in terms of thinking about people who are at risk and not at risk. This next point is about ubiquity, and I was talking a little bit about this with some folks earlier, but one of the problems with trauma, and particularly in areas of conflict, particularly in areas where there is a lot of trauma, like both areas where there's war as well as urban populations, is that trauma is frequently ubiquitous. When you have 90% of people experiencing trauma at any given time, it means everybody's experiencing it. And when everybody's experiencing something, in public health, using our typical methods, we tend to not see its effect. Now, why is that? So I just want to make this point using a very old slide from Jeffrey Rose. And this is a slide about water hardness and standardized mortality rate. I know you're all wondering why I'm talking about water hardness, but I'm just using it as an illustration. And this is shows the harder the water, the lower the standardized mortality rate. If you all look at this with the highly sophisticated statistical tool of your eyeball, you see a line right there, right? Everybody see it? So you go this way, this goes down, right? So you can say, I mean, you can do all sorts of fancy epidemiology and biostatistics on this, and that's what your professors teach you, but at the end of the day, you're going to find an association. More this way, less this way, right? So what is this ubiquity thing? Well, supposing I covered that part. Is there an association now? Not really, right? This is like sort of there, nothing. So if you study only this part of the curve, you're going to find absolutely nothing. But if you study this, you see an association. So if you're at an extreme in any distribution, you might well miss association. Now, why might you do that? Why on earth would you cover half your dots? Well, you might cover half your dots if to the right of the line is England and to the left of the line is Wales. It's entirely reasonable to do a study like this in Wales. It's just one particular area. So the point is, if you do studies in areas where an exposure, in this case soft water here, is ubiquitous, you might well miss important associations. And the problem with trauma is that if you do it, if you're looking at places where things are ubiquitous, you might well miss the downstream effects of trauma, and you might miss the foundational role of trauma in determining those consequences. And last, but linked to this, is this notion of ultimately population health. I think the best metaphor for population health is this notion of curves, in that if you have any given risk factor here, you have populations that are at higher risk and ones that are at lower risk, but the curves are definitely overlapping. This is blood pressure here, looking at civil servants and Kenyan nomads, classic Rose paradigm, and that what ultimately we try to do in public health is shift the curves, is take this curve and move it to the left. And I think traumatic events on large scale are about that. They are shifting the curve of psychopathology. They are changing the baseline of psychopathology. And what we should be trying to do is trying to shift the curve by ultimately intervening to minimize a traumatic event. I think this is where it gets very interesting about what our role is as public health professionals. Do the consequences of the psychopathological consequences of traumatic events exist if there's no trauma? Well, they don't. So it's where is it that we intervene? To what extent do we intervene upstream versus downstream? I think shifting the curve is possible. Rarely do we actually document it. This is probably from the nicest documentation that I know of, which is in a large-scale behavioral intervention around heart disease. But I think in the context of trauma, there is an opportunity for us to shift the curve if by understanding its ubiquity and by understanding that ultimately it has a tremendous range of consequences downstream worldwide. I'll stop there. Thank you.
Thank you for a fascinating talk, and our apologies for all the rain that was going on. Questions? Any questions? All right, I have a quick question. So when, with the Israeli study between Israeli Jews and Israeli Arabs, did you think of, I know you spoke about social vulnerabilities on behalf of the Israeli Arabs as being the possible cause for that disparity, but did you think about political vulnerabilities in the sense that the Israeli Arabs perhaps had the most to lose over the long term from, bombings, even though they might not have been directly involved in them, that gave them feelings of hopelessness that led to,
Yeah, no, I think I would include political vulnerability in the big bucket that I called social vulnerability. I think I'll give you a more concrete example. One of the things that one finds time and time again, when you look at age and the vulnerability to the consequence of traumatic events by age, the age group that's most vulnerable is pretty consistently middle-aged people with children. It's not the old, it's not the young, middle-aged people with children. And the thinking is that that's largely due to the sense of instability and vulnerability of one's universe, including one's children. And I think that's not dissimilar to what we're seeing here, that you have a group that is who have no stability, who are essentially hanging by a thread already. And as a result, when you are experiencing a traumatic event, it has a much greater impact. Now, there's probably mechanistic, there's probably many reasons for that. You have more limited social support, you have more limited time for yourself, you're not sleeping, all of which is ultimately resulting in physiologic changes, which probably is resulting in manifestation of a psychopathologic phenotype.
questions?
Thanks. Thank you very much for your talk. It was really, really interesting. I have a question about measurement. Are there scales out there that are culturally competent across these diverse groups you're talking about? And is there one PTSD instrument in particular that you feel has the best psychometric properties across different cultural and national groups?
Yes and no. Yes, there are scales that have been used across contexts No, I don't think there's any one scale which I think is better than the others. In a lot of the low-income country work I showed you, we used the Harvard Trauma Questionnaire, which has been validated quite extensively in low-income countries. In a lot of the high-income country work I showed you, we use something called the PTSD checklist, which has been validated quite extensively in high-income countries. So I would be careful about head-to-head comparisons of prevalences, but it's almost beside the point in a discussion like this, the head-to-head comparison of prevalences. But the larger question you're raising about cross-cultural validity of psychiatric diagnoses, this is a large and very interesting question. I think there is no question that mental health psychiatric epidemiology is bedeviled by the fuzziness of diagnosis. There's a lot written about this. I also, to be frank, don't think that, I think sometimes though psychiatric epidemiology gets unfairly labeled as having this problem of fuzziness of diagnosis, when in fact many other areas of medicine do as well. Certainly diagnostic criteria for things like rheumatoid arthritis are also pretty fuzzy, and that they have acquired a patina of certainty over time, which I'm not sure that they merit any more than, say, PTSD or depression. So I think the notion of what is phenotype is an important question. And I think, frankly, our idea of a categorical disease yes, no, right? Disease A, disease B, is a reflection of our ulterior motives. We need to label diseases because largely we need to do so for billing purposes in clinical care and also in research, incidentally. But these phenotypes are porous, right? PTSD and depression, there's a lot of overlap between them, but so is there overlap in osteoarthritis and rheumatoid arthritis.
Great. Any other questions? John.
So just many of us struggle with the concept of resilience and what that means. And I noticed that in one of the types you define resilience, but even apart from that more broadly, how do you think in this work about resilience, or is it a kind of resistance, as you talked about before?
Yeah, so here's, I have another hour-long talk on resilience, which we can do. So no, I think resilience and resistance are different. I think of resilience as a trajectory. I don't think you can define resilience at a point in time. I think resilience is a particular path over time. And I think the classic definition of resilience, which comes from engineering, I actually had a slide in here about that, which I took out just at the last minute, is a bouncing back. Resilience is about people who have dysfunction, but then recover the dysfunction. And in the slide, which I went over very quickly, I was making a distinction between resilience and resistance. And what I was calling resistance is people who have no dysfunction at all, ever, who have the trauma, have the assault, have the motor vehicle accident, have the rape, but have no dysfunction at all. And I think it is important to distinguish the two groups. I think the resistant group is, which, as I said, I think is the modal group in any event, is an important group to identify, and the resilient group is also a group to identify, to distinguish it from the other groups. So I think of resilience as a trajectory. I think there is in the public health resilience literature, we've made the mistake of thinking of resilience cross-sectionally, and I think it's not meaningful because I think that it doesn't allow you to see how things are changing over time.
Could you speak a little bit about treatment, especially for women who have experienced trauma?
Well, we can talk a lot about treatment. It depends which angle you want to take it from. I'll start with the basics. I think that if you're going to think about treatment, about intervention, let me just use the word intervention rather than treatment. In the context of trauma, in the acute period, I've become convinced that the most effective intervention is supportive intervention. It's become, in some circles, the term psychosocial first aid has come into play, which really is providing social supports and trying to alleviate those stressors that are going to compound the consequences of trauma. If you implement that in the first month after a traumatic event experience, you probably will be able to change the trajectory of some people, but just focusing on women. After a month, if then there are symptoms, now you're in the realm where treatment, in a biomedical sense, probably is beneficial. For most of the consequences of trauma, the treatment tends to be divided into psychosocial intervention versus pharmacologic intervention. The best evidence probably is on psychosocial intervention, things like cognitive behavioral type therapies, although the combination of psychosocial and pharmacologic might be better yet, although that's still very much up in the air. But I think the intervention after trauma would need to be taken in a staged manner, in psychosocial supports in the short term, watching for a trajectory, seeing which trajectory people go on, and then intervening depending on the trajectory people are on.
Thank you very much. Thanks, everybody. See you back here on March 1st. Thank you. Pass me. Appreciate it. Enjoy dinner. And I'll send you an email with the blog.
Yeah, I would appreciate it.
And
Yeah,
I can help you out.
that's great. Thank you very much. Hi.